great to have Dr. Matthew Gibbs from the University of Cape Town Department of Anesthesiology with us. Before I introduce Matthew, just to say that this program is, it's called the PBM Echo program, but it's basically from the Gastro Foundation in association with Project Echo, University of New Mexico, and these meetings are held every Wednesday on different topics related to gastroenterology, but we're fortunate to have usually about more or less one session a month on patient blood management. There is an email list, so please contact Cheryl Valentine if you would like to be added to the list. Then you will receive the invite and the links in advance. We are working on getting a better system to get the links beforehand from the Indian team, but that is still a work in progress. But in the meantime, please register with Cheryl Valentine. Cheryl, if you wouldn't mind putting your email address in the chat box, that would be great. The chat will be open for questions throughout, so please make use of that. And then without further ado, it's my great pleasure to invite or to welcome Matt. Matt has been a speaker on this platform on a number of occasions before. Matt has got special interest in a number of areas, including cardiothoracic surgery, transplantation. He's a big person in the liver transplant area, also in ERAS, early recovery after surgery. He does a lot of courses, online placements. I'm advertising you here, Matt, if people want to get you to come to teach them some stuff. He's a great teacher and a big patient blood management champion in South Africa. So he's going to talk to us about the use of iron in the cardiothoracic surgery environment, a place which is very familiar to him, and I'm looking forward to listening to you, Matt. So please share your screen. The floor is yours. For the rest of us, I think we can maybe put our videos off to save on bandwidth, and then we give Matt a chance. Matt, you're welcome to keep your video on.
All right, there we go. I should be sharing right now.
Yes, we can see it. Thank you.
Fantastic. Vernon, thank you very much for the kind welcome. Thank you again to the Echo Foundation for the invitation. I always get, whenever I get an email from the Echo team, I always find it a little odd, because one of my interests is echocardiography and perioperative use. And we use this particular model called HeartWorks. Every time I see the email address, I always think, oh, it's something about HeartWorks, and it's actually this gastroenterology, the Gastro Foundation. In fact, that's getting a hold of me. But it's wonderful to have the privilege of talking to you today about the influence of patient blood management, cardiothoracic surgery, and anesthesia. I'm going to focus certainly on a perioperative anemia and iron, but of course, it's not something that happens in isolation. Now, I'm fortunate to work in a department where I've really been invited to give this talk to the cardiothoracic department here at Cardiothoracic. Of course, this is where we did the first I use the royal we very liberally here, of course, but the first heart transplant was successfully conducted here under Christian Barnard. And so along with those sort of things, we are trying to pioneer and move towards limiting blood transfusions and optimizing our patients as best we can in an evidence-based manner. So as we go through all this, just think of it, we are trying to focus on improving patient outcomes. So this threefold matrix is very familiar to many of you. As you go through, I'm not going to go too much into the administration of IVIN today, because we've covered that a lot in previous instances. So obviously, the preoperative anemia falls mostly under the first pillar. And I think the emphasis in terms of looking at patient blood management as a whole, that it's not just about just one small section. and one person alone. It's a multidisciplinary, multimodal, patient-specific team approach. We want to optimize the patient to the best of our ability, and it's about operating on more than one thing. Anemia just happens to be a modifiable factor that has a massive influence on outcomes of patients. And by us focusing on that today, it'll hopefully have a trickle-down effect on how we manage the patients as a whole. So how we approach patient blood management, cardiothoracics, may depend on whether you're in a private or a public setting, who's going to be the champion. There are different leadership structures wherever you are within sub-Saharan Africa. And you need workers from a variety of departments, whether you're a surgeon, anesthetist, critical care is absolutely vital, nursing staff, perfusionists play a vital role as well. So it's never just about the surgeon or the anesthetist for that matter. And again, it's not just about one particular intervention. So let's start at the very beginning. What about the blood transfusions in cardiac surgery? Now, there are a variety of red cell transfusion strategies. As you can see, that depending on the various studies that have been written, the various thresholds that are determined, whether it's a hematocrit less than 25%, hemoglobin less than 6.5 while on bypass, or 8. As I said, there's a lot of different transfusion strategies. However, we do know that as soon as you start transfusing a patient, you have an increased risk of mortality. And in fact, in NICE guidance in the UK, is one of the factors by which a cardiac surgeon is judged upon his efficacy and his safety record. In this big study, 20,000 patients, there's increased mortality for any patients who got even just 1 or 2 units of blood. And as you can see on this particular graph here, you'll notice that as soon as you're getting 5 or 6 units, your Kaplan-Meier curve deteriorates remarkably quickly. This other large study, 8,000 patients. Patients who are transfused are less likely to have been discharged from the hospital at any time after the operations. They're more likely to have died at any time point. And that's strongly associated with both infection, ischemic postoperative morbidity, increased hospital stay, and increased hospital costs. Kaplan-Meier curve does not make for good reading at all. So what about our transfusion triggers? I've mentioned before, there's a variety of decision-making tools that are available to decide on when to transfuse. The TITUS study was published back in 2015, and they tried to figure out whether you're having a liberal threshold, which is based on a hemoglobin above 9, would improve the outcomes. In fact, there was no significant difference. Transfusion rates after randomization were obviously much higher in the liberal threshold group, but there was very little difference between postoperative complications between the restrictive group, where you had a hemoglobin of 7.5, well, you were transfused if the hemoglobin was less than 7.5, and the difference was remarkably little. So what about iron and anemia in cardiac surgery? So just remember that we know that iron deficiency and anemia is usually bad, and that's certainly true. And we've been through many studies that have detailed this. Just remember that iron is a common element. It's probably the fourth most common element in the earth. And it's got roles in many other things: basic cellular function, energy metabolism, cell signaling, gene expression, regulation of cell growth. And so when we see patients that have iron deficiency anemia, this is sort of like we're reaching the end stage of iron deficiency. And so by the time we're seeing patients with iron deficiency and anemia, we're probably a little bit late in the game. So it's not just about treating anemia per se, but treating the iron deficiency and the causes thereof. It's more of a continuum per se. So what about anemia in cardiac surgery? Well, it's not surprisingly, it's bad. So this Andy Klein looked at the importance of anemia in patients undergoing cardiac surgery in the UK. And with every gram per deciliter decrease in hemoglobin, there's a 43% increase in the odds of transfusion and a 16% increase in the odds of mortality. Now, that's a fairly large study. They also showed a length of stay difference as well. And this graph adequately demonstrates that as your hemoglobin level starts to decrease, your mortality goes up, as well as your length of stay. So I hesitate to show this slide because we've been through the metabolism of IV iron, and I always feel inadequate after Professor Vernon Lowe, who's an expert in iron, gives a talk. He gives a great talk explaining iron metabolism. I think it's just important to know the effect of hepcidin, which is, of course, has an effect on the uptake of iron from the GIT, and the importance of the chronic inflammatory state that many of our cardiac patients are in. Remember, hepcidin has got a negative feedback mechanism upon the absorption and transfer of iron around the body, and it's increased during iron overload as well. So we need to be aware of this effect of inflammation on the iron absorption of our patients. And so oral iron in these patients can often be very, very poor because of this chronic inflammatory state related to their cardiac condition. So there's a number of different protocols that are around to manage perioperative iron deficiency. One of the most widely cited version is this one published by Munting and Klein in Anesthesia, which gives a very nice breakdown of approach to patients with various levels of ferritin, and then breaks it down further into whether they have whether they need vitamin B12 or management for the chronic kidney disease. And I'm not going to go into the details thereof. We know that iron deficiency is the most common cause of anemia in the surgical population, and absolute iron deficiency is usually the minority, with a restrictive iron deficiency being the most, or functional iron deficiency being the most common. When we're dealing with issues in cardiac surgery, we've got this constant balance that we've got to try and optimize the delivery of oxygen to our patients. It's something that I always try and get my registrars to do, is to think about what are different ways that we're going to maximize the delivery of oxygen to the tissues, because that's what we try and do. We're trying to figure out where the patient is on the Frank-Starling curve. Giving fluid, is that going to make the patient actually perfuse better? It's not about just affecting the numbers. We know that just by giving red blood cells, we're going to make the hemoglobin go up, but will that necessarily actually make the patient better? And a number of studies have showed that that's not necessarily true. And the risk of transfusions associated with infections, costs, and other immune modulations. Now, in cardiac surgery, what's interesting is that absolute iron deficiency can be quite rare. And iron deficiency is usually functional. So this study showed, again, this is of course quite restrictive diagnostic criteria, with a ferritin less than 15, less in women and less than 22 in men. But most commonly in this population, again, we have the same figures as we had before, that absolute iron deficiency is a little bit more rare. And we're looking mostly at functional iron deficiency. So what about outcomes? Now, if the patients are iron deficient, does that necessarily mean that they're going to do worse? So this publication by Rossler in 2020 looked at a prospective observational trial of about 730 patients and assessed patients undergoing cardiac surgery for a 90-day follow-up period. They looked at mortality, serious adverse events, major cardiac and cerebrovascular events, allogeneic blood transfusion requirements, and length of hospital stay. And they broke up these patients into 4 groups according to the anemia status and their iron status. And what's interesting is they used a ferritin level of less than 100 mux per liter. Now, iron deficiency is very, very frequent in this group. So what's interesting is the very clear association of an increase in 90-day mortality. That's an increase from 2 to 5%, even without anemia. And then if they were anemic, this risk increased even further, up to 15% if they're anemic as well. And you can see that the effect of iron deficiency had a massively overwhelming effect on the increased risk of your serious adverse events, major adverse cardiac events, risk of blood transfusions, as well as all transfusions. And again, you can see again the Kaplan-Meier curves are not in its favor. There are a number of different studies that have looked at non-anemic iron deficiency and postoperative outcomes, and the Rosler study is just part of that. Interesting enough, some of the more recent publications have suggested that there's no association with worse outcomes. Some of the earlier studies suggest increase in hospital stay, transfusion, and increase in fatigue. So there is some heterogeneous results. So does giving iron help? And that's kind of what we're interested in. Surely that would make a massive difference. So what we do know is that in cardiac failure, iron has a large role to play. Absolute and functional iron deficiency is very, very common, up to 37% in patients with reduced ejection fraction, up to 60% in preserved ejection fraction, and is an independent risk factor for all-cause mortality in these populations. So the FAIR, CONFIRM, and AFFIRM trials all looked at the benefits of iron in these populations. The FAIR trial demonstrated and improved patient global assessment and 6-minute walk test and New York Heart Association class. The CONFIRM trial, using intravenous ferric carboxymaltose, demonstrated a significant increase in 6-minute walk test as a result of IV iron administration, as well as a drop in hospitalizations. And then the FIRM trial, again, showed an improvement in hospitalization. And there's a number of theories as to why that would occur. There is some suggestion that patients with heart failure tend to have reduced dietary intake of iron, and they're unable to absorb as well, because of possibly due to this inflammatory state that's not uncommon. And many of these patients present with cardiac failure. And the FIRM trial particularly looked at patients who had an acute phase of heart failure, and acute exacerbation, and they looked at giving ferric carboxymaltose at the time, and they showed this improvement in hospitalization. And many of our patients presenting for cardiothoracic surgery have an episode in the preceding 12 months that necessitates needing either emergency cardiac surgery. Sometimes they'll need emergency coronary artery bypass grafting, or whether it's a valvular issue that needs to be sorted out. So the Evans paper in 2021 looked at patients on the so-called Cardiff pathway, where patients who were anemic or had iron deficiency were offered intravenous iron infusions preoperatively, and that was at 20 milligrams per kilogram. So over 447 patients, and they demonstrated that hemoglobin concentration could be increased in successfully treated anemic patients by a mean of 1.7 grams per deciliter. And they received a very, very limited number of units of blood, and managed to successfully avoid transfusion in about 54% of patients. What is tricky, of course, is trying to predict which are the patients that are going to be responsive. As you notice that looking at your preoperative ferritin levels, the lower they are, the more likely it is that you're going to get a response to treatment. And so that's what we're trying to figure out in a lot of these patients. So whose are the patients that are going to get the most benefit? So the PREVENT trial, I think a lot of people have read about the PREVENT trial. This secondary analysis is trying to figure out the effects of intravenous iron therapy to treat the iron deficient patients. Now, this isn't a major abdominal surgery, of course, not in cardiac surgery, But what's of note is that in patients that are iron replete, there's very little response. Absolute iron deficiency has a major response in hemoglobin, but in functional iron deficiency there was less of a response than what we expected. And so it's difficult to try and tease out what the cause is of this, what seems to us very logical, that if you've got an iron deficiency and you give intravenous iron, there should be a significant improvement in the patient's hemoglobin levels. So the studies are still ongoing as to really how much can we improve patients with preoperative intravenous iron. Now, in absolute iron deficiency, oral iron can be successfully used, but you do need to give it significant time beforehand to achieve the hemoglobin results that you would like. And as I mentioned before, a lot of these patients do have issues with absorption, whether it's due to their heart failure or an inflammatory state, due to the diabetes, hypertension, cardiovascular disease. And so you got to love the name, the CAVIAR study team, the Cardio and Vascular Surgery Interventional Anemia Response. This sounds like an absolutely delicious group to be part of. And they looked at setting up iron clinics in specific hospitals across the UK, aiming to recruit patients who needed a treatment of their perioperative anemia or preoperative anemia in the cardiothoracic setting. Now, patients who received IV iron were at a higher surgical risk. They all had a slightly increased risk of or having a previous history of iron deficiency or anemia, and an increased rate of chronic kidney disease, and maybe was slightly more anemic than the non-treated group. They managed to treat these patients on an average about 33 days before surgery, and preoperative IV iron increased the hemoglobin from baseline to pre-surgery by around about 0.8 grams per deciliter. So not massive, but it certainly helped because it decreased the transfusion risk, and patients who did not receive IV iron stayed longer in hospital. So anemic patients did worse, and the number of days alive and at home was lower in the anemic group as well. So they concluded that a development of an IV iron pathway is certainly feasible within the context of the NHS, but it probably seems to be limited to high-risk cardiac patients rather than just routine patients. And I think what's important is that you can make the hemoglobin go up, but we don't know quite yet about the effects on patient-centered outcomes. And if you look at the systematic review published very recently, that they demonstrated that in patients who received IV iron, particularly in randomized control trials, that there was no difference in units transfused, in ICU stay, or hospital length of stay. There was a small decrease in mortality, but as soon as you exclude the randomized control trials, there is no benefit that is demonstrated. And the difference is a relative risk ratio of 0.58. So it's only moderate decrease. So again, I think that's something that's going to come out quite clearly, is that we need more large scale and high quality randomized clinical trials to confirm what are the actual benefits of treatment of the appropriate patients with IV iron. So we're fortunate enough to be involved with the ITAX trial. And the ITAX trial looks at IV iron for anemic patients before cardiac surgery. It's based out of Australia, part of the Paul Miles group. And we've been recruiting since, I think, 2021. And the most recent update is, as mentioned, that's the 615 patients in 9 countries. In fact, it's a whole lot more. We're 27 sites, 925 patients, and we're due to close the trial very shortly. And it's a very simple protocol in terms of identifying patients who had a hemoglobin less than 13. And if they did, they're offered a chance to be part of the trial. And it's proper randomized control. The syringes are black. Nobody knows what's in it. It's either ferric carboxymaltose 1,000 milligrams or placebo, normal saline. And the primary endpoint is clinically important outcomes, numbers of days alive and at home at 90 days post-surgery, rather than just looking at outcomes like blood transfusions, although that's often being used as a surrogate to show that patients, as we know, blood transfusions can worsen outcomes. The secondary outcomes, which I think are going to be very interesting, includes the correction of anemia from treatment to day of surgery, red cell transfusion, postoperative complications, hospital stay, disability-free survival. And I think what's going to be very interesting is they're also being assessed by using the HUDAS disability scores, heart disease questionnaires, quality of life, which I think is very important in patients post-operatively. We know that patients who are iron deplete do worse from a functional point of view post-operatively, and in fact at any stage in life. And this is for follow-up up to 6 months. And the interim results are very interesting. We've got the mean hemoglobin not that low of 11.8. 40% have evidence of iron deficiency. That's a ferritin less than 100 or TSATs less than 25%. And the most, about 60%, have had coronary artery bypass grafting. So the initial results probably only be published next year. The target is 1,000 patients in total. And it's going to be very interesting to see what are the results of this well-designed, a well-conducted multi-site trial. In terms of post-operative iron in cardiac patients, there are limited studies. Most of the studies are small randomized controlled trials that demonstrate limited effects on the hemoglobin. They certainly demonstrate there's an improved reticulocyte count, and that oral iron is generally poorly tolerated, which makes sense in the post-operative setting. Patients do not going to absorb very well, not going to be super compliant, especially because of the side effects. And the evidence tends to be low quality. So what we, as I've demonstrated earlier, I think most of the evidence comes from your chronic heart failure patients, which have improved quality of life parameters, which I've said that's one of the interesting things of the ITAX trial. Improved the number of hospitalizations, exercise capacity. I think that's very important to look at quality of recovery after major cardiac surgery. And in fact, patients' ejection fractions seem to improve with the appropriate application of iron. So in the final part, I just want to say it's not just about iron. And I've mentioned, of course, the first parameter, but cardiac surgery, there's so many different aspects in terms of what's going on. I mean, I was doing a case yesterday, a patient who had an aortic root abscess secondary to infective endocarditis, and these patients tend to bleed a lot. And what we're finding really beneficial in these situations, where previously we would have just ordered packed cells and platelets and cryo just in case, assuming that the patient is going to bleed post bypass, the use of point of care viscoelastic testing is completely changing how we approach the perioperative coagulation issues. Some of the newer circuits that we use can make a big difference. Smaller priming volumes, shorter lengths, smaller artificial surface within the reservoir, biocompatible heparin-coated tubings, and basically try and avoid blood-air contact, which stops the issues of destruction of red blood cells. Try reduce the amount of hemodilution that occurs. As I've mentioned, point-of-care viscoelastic testing. There's TEG6, which is now available, which can be performed by anyone with a syringe and time to just put the cassette in, and gives us answers within 10 minutes. And we were able to recently, with some major aortic root surgery, we were able to avoid using blood products. Cell salvage, I'm not going to go too much into cell salvage, just to say that using cell salvage in cardiac surgery makes a massive difference. It'll, on average, it'll reduce at least 1 unit of packed cells, sort of a weighted mean difference of less than 256 mils. Although there's no difference in hospital mortality, it just means that these patients just have a reduced rate of exposure to any allogeneic blood products. So the more we use fairly simple, what to us is fairly simple methods, could make a huge difference to the patient in the long term. There's lots of different protocols for point of care coagulation testing. Basically, there's all these different strategies depending what you look at. They've demonstrated that you can reduce mortality or risk of acute kidney injury, reduce thromboembolic events, transfusion, obviously, reduced amount of fresh frozen plasma, and that, of course, reduces your risk of TRALI or transfusion-related acute lung injury. There's no big difference in stroke, of course, and reduced re-exploration rates due to postoperative bleeding. So there's can be massive benefits from using these tests. Reduces your bleeding as well. So we always advocate the early use of viscoelastic testing if you have it, and if you don't have it, I would highly recommend looking at the South African Patient Blood Management Guidelines. There's a lot written there about viscoelastic testing in the cardiac section, and speaking to your hospital manager and advocating that you're going to save time and improve your patients by using it appropriately. And there's lots of different protocols that are used, and in this particular case, in patients who had taken clopidogrel before, they also magnified the results, and the cost savings were in the region of around about £2,000 per patient. So lots of guidelines on patient blood management for adult cardiac surgery. The ACTA guidelines in 2017 are very, very useful. There's more up-to-date 2021 guidelines. And I think this is probably a nice way to close off. There's, again, similar to our 3 pillars that we mentioned earlier in your 9-fold matrix. You've got your pre-op and intra-op and post-operative phases, restrictive transfusion triggers, treating your anticoagulation, using goal-directed transfusion algorithms, point-of-care coagulation testing, and some of the other measures that I've mentioned. So in summary, anemia is an independent risk factor for poor outcomes after cardiac surgery, and we can probably modify it and reduce the risk of allogeneic blood transfusion. We know that patients with absolute iron deficiency will benefit most. Get your timing right, and that's going to be critical, is identifying these patients early before they come in on the day of surgery. If you're seeing the patients with a hemoglobin of 10 on the day of surgery, you're probably going to say HB of 10, it's not too bad, but you're really setting them up for worse outcome. And if you can try and treat that, perhaps we will have an improvement in our outcomes. You'll certainly be able to decrease the risk of them receiving a blood transfusion. As I say, the jury is still out how much we can to improve patient absolute outcomes, but we need to try and figure out what patient population will have the maximum improvement in outcome, whether it's the non-anemic iron deficiency versus anemic. So, as I said, iron therapy does help, and treat it appropriately, investigate the patients. And let's see what comes out later this year with ITACs, and there are a number of ongoing trials that will help us just to try and tease out exactly which patient's going to benefit the most. Let's continue to measure and diagnose, work up and treat our patients appropriately. And most importantly, we need to follow up. It's not just a matter of giving IV iron and saying, hey, I've done my job. We need to see if our patients respond, and then see how they do. And I think it'll be very interesting to see the quality of improvement, the quality of life for these patients in the post-operative sphere. Thank you very much.
Matt, thank you so much. Excellent talk as usual. I would like to welcome anybody who want to put up their hands or put questions in the chat to do so. But while we wait for that to happen, oh yeah, there's a first question already from Noel Zulu. Fantastic presentation, very clearly articulated. I totally agree. Would there be a difference if we use IV iron in the septic patient? I noted the study focuses in the cardiac surgery patient.
So could you say, Vernon, could you just say that again? In
So
septic
would there be
cardiac
a
patients or
difference?
just septic patients? Sorry, let's look at the question.
Noel, are you talking
Okay.
about septic patients in general or the septic cardiac patient?
Just the septic patient in general, sir.
Septic patient
Septic
in
patients.
general.
Okay. I would be very hesitant to use iron in sepsis that is a patient is clinically unstable. I think Vernon has talked about this before. You would certainly want the patient to be in a more stable condition before starting intravenous iron. Vernon?
Yeah, no, I totally agree. It's a very interesting topic that is not fully explored. Maybe just a few comments on this that could be useful to the group listening, because I know not all of us are cardiothoracic surgeons. So the first thing is that iron seems to be very important in the immune system, but both let's say in all aspects of the immune system, there are now numerous studies showing that vaccine responses are inadequate in iron deficient children and people, for instance. But we also know that patients with asthma and allergy, there are interesting studies now showing that iron deficiency may make allergies worse. So I think some examples of how broadly iron plays a role in the immune system. Now, in terms of infection, of course, bacteria and fungi and many organisms live on iron. And that is why hepcidin goes up during an infection, is to hide the iron away from the infective agents. So one wants to be careful in that setting. Now, there is some conflicting data where in some instances it has been thought to protect against infection, but I think most people feel safer to first treat a patient with antibiotics until they are clinically stable before giving iron. So that's my position at this point in time as well, but we're watching the literature. I see Dr. Igembe N mentioning from Tanzania, we have a lot of sickle cell patients in Tanzania, and some of them have coexisting iron deficiency. Any comments on perioperative anemia management?
I'm going to respectfully say I have very little experience with sickle cell. We see them very occasionally at Red Cross Children's Hospital, and I've seen one or two. So I don't think I could really make an informed comment on that, although it does make a lot of sense. Vernon, do you have any experience? I mean, you're the hematologist.
Yeah, so Dr. Igembe, it's a difficult and technical topic because sickle cell anemia patients more often have iron overload, which cause its own problems, a range of problems, of course, including effects on the endocrine system, liver and heart and so forth. So one wants to be very sure that it is definitely iron deficiency and not concomitant thalassemia, thalassemia minor in particular, which may cause things like a low MCV or a low MCH that may look like iron deficiency. You must make sure from a biochemical point of view that your sickle and or your thalassemia patient really does have iron deficiency. The second issue, of course, is the whole one of malaria in the malaria areas where you may be working, that you might want to be sure that your patient doesn't have active malaria, because iron can, of course, be a problem there potentially as well. And you specifically asked about the perioperative anemia management. If a patient doesn't have malaria and they have proven iron deficiency, the perioperative management, I would think, would still consist of giving them iron. Again, patients may need to have iron earlier depending on the severity of anemia, which may be worse in the sickle cell disease patients. So 2 weeks may not be enough. So depending on the starting point, you may want to start a little bit earlier perhaps, but make sure your patient doesn't have an infection on board would be my major takeaway.
Yeah. Mm.
Matt, may I ask you to quickly share your screen again while we're waiting for any further questions? I would like to go back to a slide you showed. It was the Andy Klein study. I would say sort of halfway through your presentation, you had the graphs showing outcomes on the y-axis and hemoglobins on the x-axis.
Not the Evans trial.
No, I think it was before this one, perhaps. If you want to, then if you want to see show your slide sorted, then I can quickly tell you which one it is.
Yeah, I'm just. Was it this? Not this Klein study.
Yeah. Next slide. I think.
The next slide was
No. So.
Were you looking at the prevent
No,
trial?
it's not the prevent. Earlier. There's a slide with there's two graphs next to each other with
that one.
No.
That's the Rossler study.
No, it's the one with
was it this one? Yes.
There we go. That's a Klein study
yes.
on the incidence importance of anemia.
Yeah.
I think this is an important slide with a very important message. Correct me if I'm wrong, Matt, but the way I remember this study was that the red and blue represented female.
Male and female. So men are on blue and women are on red.
That's right. So what I think we should see here, and it's maybe important for everyone to be aware of this debate that is ongoing about whether men and women should have the same reference range for hemoglobin, because currently the WHO states that a normal hemoglobin for men is 13 or above, and for women 12 or above. So Matt, I think you know where I'm going with this. Do you want to make a comment on what this study showed?
Okay, so I think you can see that there is a difference in mortality. So there's the length of stay, and I think it was here.
Yes.
Yeah. So I think the point was that the difference in mortality even below 13 starts to be apparent.
So normally we would have thought that a hemoglobin, the mortality should only increase for women below 12, if it is true that a hemoglobin of 12 is supposed to be normal for women. But we see that it already starts in a relatively linear, well, almost exponential fashion from below 13. So women already have an increase between 12 and 13, which tells you that women's normal HP should probably be the same as men, because there's no difference in mortality if you follow the HP decrease between men and women.
Very clearly there. And you can see that the women at 11 are already at a disadvantage.
That's right. So keep that in mind. It's an interesting area of discussion and debate in the patient blood management world and in the transfusion medicine world, whether we should change what we consider to be normal for women compared to men. I think the other interesting message there is that many of these studies on so-called non-anemic iron deficiency, where an HP of, let's say, 12.1 would be considered non-anemic in women. But if you then treat these patients with iron, the hemoglobin goes up, which tells you that they are actually anemic, because their hemoglobin goes up significantly.
Yeah.
So watch the space. I'm one of the people that do believe that we are not treating women the way we should, that women should should be having a higher HB than what we're currently leaving them with. And I see Gareth Cantor say that might be the most important take-home messages. Ranges for men and women should be the same. Yeah, I think
it's an artificial disparity.
Correct.
If you measure patients, if 40% of your population happen to be iron deficient, they are going to have on average a lower mean hemoglobin, and so therefore you're going to come out with a mean hemoglobin of 12 versus 13. But you're saying what's normal. Our patients are actually iron deficient, and in population 18 to 40, it's far more than we expected. It's interesting to note that on the patient blood management WhatsApp group, there's been comments recently about the high proportion of patients, of ladies presenting, who are actually iron deficient, and not even necessarily anemic. And that, I mean, you're an expert. You've had many talks about the effects of iron deficiency on outcomes, on cognitive outcomes. And so we're missing out on adequately managing these patients. You're absolutely right.
Thank you for that, Matt. By the way, talking about the WhatsApp group, if anybody is not on our Sub-Saharan Africa PBM WhatsApp group, you're welcome to join. You can email me at that email address that I've just put in the chat group. Email me. I'm actually on sabbatical leave at the moment, as you can see by my clothing. So I may not be as responsive and as quick as usual, but just email me.
You can also email me as well. I'm happy to.
Okay, fantastic. Matt, don't you want to put your email address in there as well? I'd like to quickly share a slide. Matt, you've stopped sharing, right?
Yeah, I've stopped sharing.
Let me see if I can. I want to quickly show a slide that I think is very, very interesting and illustrative. And it's this one. Can everybody see it?
Yeah, coming through.
Right. So this is not my slide. I need to acknowledge Jeannie Callum from the Canadian Blood Service who shared this with me. And I think what this slide shows is basically why we are sitting with all the problems we are sitting in terms of trying to figure out what is normal. We're busy writing an article with a group on all the different tests for iron and hemoglobin and all that, and all the controversies. And the reality is that the studies done so far have not really used an appropriate population. They would often use either so-called healthy blood donors, and we know amongst blood donors that the rate of iron deficiency is up to 70%, 70, or they would use so-called healthy young women, where we know in the Western Cape alone, 57% are iron deficient. Because a patient with a normal hemoglobin and otherwise healthy doesn't mean that they're not iron deficient. We know that there are significant problems. If you want to do this properly, and this is what you should do. This is how you should select your patients. And it's going to take a lot of work and a large study. But you need to first exclude all patients with anemia. That's where most people stop. And then exclude all females below 55. Then all people over 80. Then all with MCVs, you know, that are low. And then all and so forth and so forth. And you can see that you will end up with a very small number of patients, but that will actually help you get to the right normal range. Now, I challenge anyone to go out and look at studies to go and see who's done this when they decided what a normal ferritin is or a normal HB for women, etc. This is unfortunately not happening, and that's why we all struggle to know what is true. So this is a study that I believe needs to be done, and needs to be done properly. This is sort of, I think, how somebody estimated what they would need to get to a number of about 200 cases. So I thought that would be hopefully useful, just to understand where the problems come from, the history. Great. Any other questions? Can Okay, Matt, any last comments from you before I
So we've
say
had
it?
I've had some very good chats with positive conversation with the cardiac department and cardiothoracic department, and we're looking to try and formalize a pathway for these patients in conjunction with cardiology. So we're trying to set up a meeting with cardiology to be involved to identify these patients early on prior to their surgery. And so as I mentioned, that the earlier we treat these patients, I think the better they will do. And once a formal program is sorted out, I think we'll see a great end result for our patients. Yeah.
Thank you, Matt. And I just want to say thank you again to you for all the great work you've done in patient blood management in the last couple of years. It's been an awesome privilege to work with you. So positive, such a good teacher, and always so well prepared. Thank you, Matt. And again today. And I think, you know what I really like about your talks, you know, I'm sort of the dinosaur sitting on iron, but you come with a whole spectrum of interesting things that I think is so important to add as well. And I really appreciate that very, very much.
Thanks very much. Appreciate it.
With that, I'm going to say thank you. Thank you to Echo University of New Mexico and the Echo India team. Recordings of the talk will be available on the Gastric Foundation website, so please go and use that and share the links with other people. Really like to thank the Gastro Foundation, Chris Cassianides, who couldn't be here today, but sent his apologies. Thanks to Chris, thanks to Cheryl, thanks to Karen, thanks to our sponsors. Next week will be lower endoscopy as the topic of the week. I'm sure for the gastroenterologists that would be very relevant, and I hope you enjoy that. From our side, once again, just to remind you of the comment that we made in the beginning, if you are not receiving the email invites to these meetings and the links, then please email Cheryl Valentine. And Cheryl, maybe for the people who came late, you can just, if you don't mind, put your email address again in the chat. Please put your name on the list so that you get the links in time and put it in your diaries, because we're going to have many more great sessions like these. And there's some good speakers coming up for the rest of the year. With that, I wish you all a wonderful evening and thank you very much.
Thank you all.
Thanks, Matt. Thanks, Cheryl.